panel discussion. If there are any questions, Dr. Kaur will be in the hall and we could discuss something. Thank you again. And thanks to the We Care team for inviting us. I give it to my co.
Thank you. Over to the organizers.
Thank you. Thank you to our esteemed chairpersons for chairing our session. Yes. All right, very quickly, I know lunches are waiting, so we will try and get our panel moving as fast as possible. I would like to invite to the stage our 4 panelists, our 4 doctors who are going to be in attendance for our patients today. Dr. Jugal, come along, please. This is our first doctor. So we're going to keep this as, these are 3 patients we are meeting today, Sita, Geeta, and Meeta, all 3 best friends, all with their individual endocrine problems, have come to the office. The goal over here, they want to meet all the best specialists in town, and as a result of which, they're meeting our 4 doctors over here, Dr. Jugal, our first one over here. Everybody has their CVs. I'm not going to be reading out our CVs over here, if that is all right. Dr. Richa is our second panelist for the afternoon. Hi, Dr. Richa. Also from New Delhi, welcome. Dr. Nilakshi, our third panelist for the afternoon, please. We'll need one more chair. Jugal, you can just straighten it out a little more so that way everybody is visible. And Dr. Sunetra. We could just flash the CVs, please, as we are Dr. Nilakshi's CV and Dr. Sunetra's CV also, please. Dr. Nilakshi is here with us from Guwahati. And Dr. Sunetra is from Durgapur. So very quickly, we're going to move on to our first case for the afternoon. So we've extended this from a little bit from fertility into pregnancy also as well, because that's not been discussed through the course of the conference. And I'm going to be running through some cases. The patients over here, we are saying they've come into our offices. And so we're just going to quickly run these questions by all our 4 doctors over here. Okay, so this is case number 1. We don't have slides in this. It's just going to be a conversational piece. Our doctors are going to be giving advice as they would do so in a clinic. So this is our first case. The patient, Geeta, she's a very pleasant 8 weeks pregnant female who's been referred to the doctor by her gynecologist for a little subnormal TSH, 0.1, a little elevated free T4, which is 1.9. She was recently admitted to the hospital for hyperemesis. She has no family history of thyroid disease, no goiter, no orbitopathy. So at this point, she's come to Dr. Jugal to his clinic with these little abnormal TFTs. The question for Dr. Jugal is, the patient asks, what's going on with my thyroid, Dr. Jugal? What would you advise?
Thank you so much. So this patient has come with a little low TSH. The FT4 is slightly high. As ma'am mentioned, there is no evidence of goiter or hyperthyroid symptoms besides that. When we come across such patients, there are a couple of differential diagnoses that you need to keep in mind. The most common is hyperemesis gravidarum or an HCG-mediated TSH suppression, which is very commonly seen in pregnancy. It's because the HCG has a little effect like TSH, and when the HCG rises between 8 to 12 weeks, you can have an effect on the TFT. The goiter part of the story and hyperthyroid symptoms rules out the Graves' disease part of the story. However, it's always better to do a TSH receptor antibody and an ultrasound to confirm there is no trophoblastic disease as well, because trophoblastic disease will also present with a high HCG relating TSH suppression. So there are 3 DDs. One is hyperemesis or an HCG mediated thyroid suppression. Second is a Graves' disease, and the third is a trophoblastic disease of pregnancy. Thank you.
All right. So over here, and Dr. Jugal, what would be your next best step to work this up a step further? What would you do in this kind of scenario now?
So I would do a TSH receptor antibody, a USG OBS, and obviously repeat the TFT after a couple of weeks, like 2 weeks for sure, to look at the trends.
Okay. So our next question over here is for Dr. Richa. Dr. Richa, so this patient has had bad obstetric history. That's the reason her obstetrician actually sent her to you with these slightly abnormal tests. She has had past 2 miscarriages. So my question over here is, with this kind of thyrotoxic state, what is the impact of hyperthyroidism on infertility?
So thyrotoxicosis definitely decreases fertility, and even when pregnancy occurs, there is increased incidence of pregnancy loss and other complications like fetal growth restriction.
A little closer. Can't hear you too well.
Like fetal growth restriction, preeclampsia, perinatal mortality, and congestive heart failure in mother. And why do these changes occur? The mechanisms, certain mechanisms have been postulated. There is there is increased conversion of androgens to estrogenic byproduct, which may be one mechanism which is also responsible for gynecomastia and erectile dysfunction seen in 10% of thyrotoxic men. Other way thyrotoxicosis may affect fertility is by effect of thyrotoxicosis on GnRH signaling, which disrupts the LH-FSH pulse and frequency, resulting in decreased fertility.
Thank you so much. So as per Dr. Jugal's advice, the patient does the recommended tests. She does an obstetric ultrasound which rules out any trophoblastic disease as a single viable pregnancy of 9 weeks. On ultrasound of the neck, you see basically there's a diffuse symmetrical goiter and her TRAB antibodies are positive. Of course, an important point over here is that one cannot do a radioactive an uptake and scan, a thyroid uptake and scan in pregnancy, which is why the usual gold standard test cannot be used for this particular pregnant patient, and that's why we need these surrogate tests, the ultrasounds and all of these clinical symptoms, the signs, symptoms, and these other surrogate tests to make our diagnosis. So we're here with TRAB positive, with her ultrasound showing a diffuse symmetrical goiter. Our diagnosis of Graves' disease is confirmed. Now we repeat her TSH. It has now come down to a 0.01. Her free T4 remains a little high again at 2. So Dr. Nilakshi, would you consider treatment for this patient at 9 weeks pregnancy with a confirmed Graves? Is she a candidate for treatment at this point of time?
In fact, yes, very much yes, because as we know, thyrotoxicosis or Graves' disease can have both adverse maternal as well as fetal outcomes. Hence, it is important to treat Graves' disease during pregnancy in order to avoid these outcomes. But we should also be careful about the medications that we use, because having thyrotoxicosis during pregnancy is risky, as well as the treatment for that is very risky. So there has to be a balance between the two. But we do need to treat, because in this case the TRABs are also positive. Though our treatment goal would be to treat free T4 levels to higher normal range, not really bring it down to the lower normal range, but we do have to treat in order to avoid the adverse pregnancy outcomes.
Fair enough. So Dr. Sunetra, the question is, at this point, first trimester of pregnancy, we are kind of at a balance about whether to treat the thyrotoxicosis. Are the medication related side effects going to be the bigger problem over here? What is your choice of treatment for the Graves' disease in this first trimester? And as she progresses into the second trimester, are we continuing the same medications? What are we doing and why?
Yeah, thank you. So as has been discussed, treating Graves' disease during pregnancy is very dicey, because the antithyroid drugs cross the placenta and can cause fetal hypothyroidism. Again, the TRAB antibody also crosses the placenta, which can cause fetal hyperthyroidism. So it's a very subtle balance. So during first trimester, given the risks of both propylthiouracil and carbimazole are low, but then the risks with propylthiouracil are less severe than that of carbimazole. So I would start her on propylthiouracil, maybe at a dose of 200 to 400 milligrams to start with. And I will continue propylthiouracil till the 16th week of gestation, following which, depending on her response, provided she is not having any pregnancy related or otherwise liver problems, and after discussion with her, after 16 weeks, I may consider shifting to carbimazole or continue with propylthiouracil itself, with close monitoring of thyroid function, TRAB, and ultrasound of the fetus.
Fair enough. So the idea over here is that maybe we start with PTU first trimester, move over into a neomercazole, that family in the second trimester. But Dr. Jugal, in this first, throughout pregnancy, what are our goals for thyroid function, as has already been explained briefly? How do we continue? How frequently would you do her tests? What tests would you do? Would you be repeating antibodies during the course of gestation?
Yeah. So first and foremost, once you start the treatment, you try and target the FT4 levels. The free T4 levels should be kept at the upper limit of normal for the assay which you're using. Try and keep the same lab, because every lab has a very different assay and a very different cutoff. So whichever lab you're using, keep to the same lab, and whatever is the higher value of the FT4, just keep it there or slightly on the higher side. Do not chase down the TSH. Chasing the TSH is a mess. So always chase the FT4 and titrate your doses accordingly. When you are on a higher dose of carbimazole or a PTU, what you need to do is probably you could do your TFTs a little too frequently, like every 2 weeks. Otherwise, a good 4 week is more than enough, so that you can start minimizing the doses, because at any given higher dose is far more detrimental for the fetus than the lower dose. Coming to the TSH receptor antibody, you should do once between 18 to 22 weeks and between 30 to 34 weeks. A titer which is going down makes you much more confident of decreasing the doses. And if you're about to stop the your carbimazole or your PTU, then obviously if your titers are high and they are positive, you may want to continue a lower dose for safety.
So, Dr. Jugal, what might happen in the course of pregnancy now that we generally find with Graves' disease?
So generally, over the course on second or third trimester, the autoimmunity usually starts going down, and the patients go into remission most of the time, and the antibodies come to a very low or negligible level, and you would be able to stop antithyroid drugs in most of your pregnant patients.
So that's a very important point again. All autoimmune conditions tend to go into remission during pregnancy, as a result of which, even with Graves' disease, very likely by the mid-second trimester, in a lot of patients, antibody levels go down, the thyroid function corrects, and we very often can wean off the antithyroid drugs as well. So that's what happened in our case over here. We tapered off her antithyroid medication by her mid-second trimester with frequent testing like was suggested, and she remains euthyroid for the rest of her pregnancy. And congratulations, thanks to the excellent efforts by all our doctors, this patient now delivers a healthy female fetus of 2.8 kilos. Dr. Richa, at this point of time, the patient now asks you, what do I do with regards to my thyroid? Has my thyroid problem gone away forever? Is this likely to come back? Is my baby, what's going to happen with that? Am I able to feed her comfortably? What is that you're going to counsel the patient?
So, as you were saying, pregnancy is a state of immune tolerance where mother has to accept the fetus with 50% of foreign paternal antigens. So there is immunosuppression, and autoimmune diseases like Graves' disease, they tend to become silent, tend to become quiescent. But when delivery occurs, when the pregnancy is over, this immune tolerance also goes away, and there is exacerbation of immunity. Before returning to normal level, there is actually an exacerbation. So if the patient was not requiring any ATTs during pregnancy, there may come a requirement after delivery. Actually, if you take the history of Graves' disease patient, many of them would tell that they delivered a baby in last 1 year. I mean, after the delivery, the immunity sort of exacerbated. So the antithyroid drug requirement might increase after the delivery, or it may come back if it was not there during the pregnancy. And if a patient requires antithyroid drug during a postpartum period, can she breastfeed? The studies have shown that a very small amount of antithyroid drugs, both PTU as well as methimazole, happens in breast milk secretion. So they are both secreted in breast milk. Earlier it was thought PTU does not, but it's not true. Both are secreted, although in a very small quantity. And again, it has been seen there is no major risk as long as we are using mild to moderate dosages, which is around 20 milligram of methimazole and around 350 milligram of PTU. If a patient is requiring very large doses, then breastfeeding may not be recommended, but with moderate dosages it is fine, and there is no effect on fetus growth and on the neonate growth and development and neurological development has been seen. And how do we monitor the neonate? Do we need to do the thyroid function test repeatedly if the patient is taking antithyroid drug and breastfeeding? Not exactly. We really don't need to do that. What we need to monitor is growth and development of the child.
So that's the important message over here, that when the patient feels that, hooray, my thyroid problem has completely disappeared in pregnancy, you have to tell her at that visit when she's coming to you for her thyroid function in pregnancy, her last visit may be prior to delivery, you've got to tell her this is likely to exacerbate itself post-delivery. You need to come back because following delivery, the mothers tend to forget about themselves, the whole focus goes on the baby again. If they have symptoms also, they might feel that their symptoms of hyperthyroidism are related to, lack of sleep and all of those other related issues. But you've got to tell them that this is likely to go back up again, the thyroid levels. It's important to follow up for yourself as well. So that was our case number 1 with regards to the management of hyperthyroidism pre-pregnancy and post. We are moving now to our second case. This is our first Geeta's friend Sita. So when Geeta recommended you as a doctor, Sita came to you. She's a 30-year-old female. She was recently diagnosed with type 2 diabetes. And she comes to you where she's already on a maximum dose of metformin. When she presents to you, first Dr. Nilakshi, her blood sugars are at a level of 120, post-meal sugars are at a 160, her A1C is 7.1%. So her main question at this point, she's 30 years old, she's been married now for a few years. She asks you, Dr. Nilakshi, Doc, will it be hard to get pregnant with my current situation? What is your advice to her?
Yes, diabetes is often a risk factor for subfertility in women because diabetes can affect a female in very different ways. We know diabetes and obesity are interlinked, so in that way, obesity in diabetes can lead to anovulation or oligoovulation in a female, which can decrease her fertility rates. Again, having diabetes, we also have an increased incidence of PCOS in these women. So that angle also has to be considered when she is planning to get married and getting conception. Diabetes is also known to increase stillbirths, miscarriages. It is also linked to increased congenital birth defects like neural tube defects or cardiac defects. It can lead to fetal macrosomia if the mother has uncontrolled hyperglycemia or diabetes and obesity in pregnancy. That can lead to macrosomia, which can lead to complicated deliveries requiring the newborn or neonate to increased requirements for ICU, intensive care unit treatment. Again, mothers having diabetes, they are also, since it is considered to be a high-risk pregnancy, they also have a higher risk of requirement for cesarean section, and again there's a risk of having C-section wound infections or poor wound healing in such women. Again, children who are born to diabetic mothers, they kind of tend to develop metabolic syndrome more frequently at a later age. So they are also more prone to develop diabetes, childhood obesity at a later age, and develop the same. It's a transgenerational propagation of disease. So that has to be counseled to the mother, and that is where pre-conception counseling becomes very important in such scenarios, to counsel her in a way to maintain an ideal body weight, to keep her diabetes under control, to avoid smoking if she's already doing, to avoid alcohol, to eat a balanced diet, regularly exercise. All these play a very vital role when we are treating a woman who is a potential candidate for pregnancy or a woman who is in her reproductive years.
So I think that's again a very important point that Dr. Nilakshi brings up, that it is really the mothers who are leading to future generations of children with diabetes as well, and probably catching this patient at this point of time, explaining to her what is the role of tight glycemic control even prior to conception, during pregnancy, is going to prevent us, getting future generations of diabetes and avoiding India becoming that diabetes capital of the world at some point of time. So Dr. Sunetra, at this point of time, when Sita is with you, what do you explain to her where she's come with sugars of 120 fasting, 160 post-meal, A1C of 7.1%, not terrible, but pre-conception, are these glycemic goals different? And any other tests that you would recommend to her at this point of time also as well?
Yes, so if we go by most of the guidelines, the target pre-conception HbA1c is less than 6.5. Anything above 10, we should recommend against planning conception at this point. Hers is reasonably good, of course, provided she can achieve more stricter fasting and post-meal glucose control in a few weeks or months. Apart from that, given she is having a known diagnosis of diabetes, and pregnancy is known to aggravate at least the microvascular complications of diabetes. I would also check her serum creatinine, urine albumin creatinine ratio and do a fundus examination. I would also look at this as an opportunity to look whether she is having any thyroid dysfunction and her blood pressure. I would review her medication to ensure she is not on any statin or any ACE inhibitors, ARBs, and as mentioned by Dr. Nilakshi, so that she maintains a healthy habit. Regarding other tests like serologic testing, STDs, I would refer her to my expert obstetrician colleague, of course.
Right, fair enough. So Dr. Jugal, now she's doing her maximum in terms of lifestyle management, and her A1C is right now still at a 7.1%. We know that she's going in for a pregnancy. At this point of time, you face this big question about, do we want to further tighten her diabetes control prior to going in for pregnancy planning? Would you recommend any more oral drugs? Would you recommend insulin? What would be your plan at this point of time?
Yes, obviously you need to get the A1Cs better than 7.1 for sure. You need to get it less than 6.5 ideally, as they were just mentioning. And since you've exhausted metformin and the rest of the medications wouldn't be safe if she conceives, it's better to start the patient on insulin. So you tide over that rubble, because once you are on an OHA and you get pregnant, again shifting to insulin, the glycemic control goes haywire. So you counsel the patient, begin her on maybe just a basal dose or a basal bolus or a premix as it would be necessary depending on the sugars. Make her understand the insulin education, because that is where it takes time even once you're pregnant, once you start them on insulin. So even that part of the learning curve is done, and get her sugars very nicely and tightly controlled at around 6.5 A1C, or a fasting which is less than 120, and a post lunch or an after meal less than 150 or 155. That really helps you titrate things further.
So yes, I think this is a very good opportunity to starting patients on insulin, because if her control is like this pre-pregnancy, we know that as soon as she gets pregnant, the sugars are going to go much higher. And women generally during pregnancy are more open. If you give them the fetal angle, fetal safety angle, they're more open to the idea of initiating insulin. So it's a good opportunity. Having said that, Dr. Jugal, would you consider if the patient is absolutely reluctant for insulin? What is your opinion about acarbose, about glibenclamide? Do you use these options at all?
So currently I've not been using both, but there is evidence for both in the literature, especially glibenclamide, which has been used also. But most of the guidelines, whether they are international or national, have recommended that you should use your glibenclamide only in the lower socioeconomic strata where there is a problem in insulin as well as the monitoring of sugars, and becomes a little safer option. However, glibenclamide crosses the placenta and there are higher chances of fetal hypoglycemia. So if given a choice, I would counsel the patient against the OHAs and just continue with metformin and insulin.
Insulin, fair enough. So Dr. Richa, under your excellent care and your guidance, this woman loses 15 kilos. Her A1C now even off metformin has come down to a 5.6%. And again, congratulations, she's conceived. She's now come to you for her first antenatal visit. We're at 6 weeks of pregnancy. So at this point of time, Dr. Richa, would you retest sugars? She tells you, I've just done my sugars, everything A1C is 5.6, but now she's pregnant. Do we need to recheck pregnancy at this first antenatal visit point? What is the importance of all of this process, and how does diabetes affect pregnancy primarily?
So it is very important to check blood sugar levels at first antenatal visit. This patient I would call, this is type 2 diabetes controlled on lifestyle modifications, but she still has diabetes, and diabetes controlled on these measures. And diabetes and pregnancy is a diabetogenic state. We know placenta, which connects baby and mother, it makes hormones, produces hormones like HPL, which are going to increase sugar levels. So we will check at the first antenatal visit. The degree of hyperglycemia and other associated comorbidities and complications of diabetes are important throughout the pregnancy, and if not properly controlled, diabetes may result in all those complications in fetus like fetal macrosomia, hyperbilirubinemia, hypoglycemia, and fetal demise, fetal anomalies, spinal anomalies, neonatal respiratory distress syndrome. So it is very important to control sugar levels within target, and very important to check whenever we have the opportunity in the first antenatal visit and keep following that.
Excellent. So Dr. Nilakshi, what is the test you would do at this point of time during her first antenatal visit? Do you do fasting sugars, PP sugars, A1Cs? Do you do an oral glucose tolerance test? What is your test of choice?
Very often we come across patients with diabetes who are already on treatment, say they are on metformin or on insulin, and we see the treating gynecologist asking for an oral glucose tolerance test. So this should not be done because the patient is already diabetic and she's bound to have an elevated level that defines diabetes. So that is not the test that we should be asking for, and we should be asking for a fasting PP and an HbA1c. So we can do the fasting with levels of which should be around say less than 100, less than 95 to 100. 1 hour PP we should target to be somewhere less than 140, and the 2 hours postprandial blood glucose level should be somewhere close to 120 or lesser if possible, without placing the mother at an increased risk of hypoglycemia. So that point always has to be kept in mind whenever we are treating a woman, that we should try and achieve these levels and an HbA1c of between 6 to 6.5, provided we are able to avoid dangerous hypoglycemia to our patients and achieve these levels. So safely achieving these glycemic targets that should remain in our mind while treating such patients.
Fair enough. So one thing which is important again over here is that for patients who are already patients with diabetes, already on management, yes, we would be monitoring the fasting and PP and through SMBG or whatever that might be on a regular basis. Of course, HbA1c is something that you don't want to repeat that often. It's not going to guide your immediate management. However, for patients who don't have diabetes, known diabetes in the past, when they come for their first antenatal visit in India, we practice universal screening for all women at the very first antenatal visit. We do not wait till the 20th week, 24th week, etc. At the very first visit, we need to do this. And for women, basically the DIPSI is what we do. It's a 75-gram 2-hour glucose test. If this is more than 140, it confirms the diagnosis of GDM. So now for this particular woman, she has diabetes, we know so suppose her sugars are now on the higher side. Dr. Sunetra, what are your next steps in management over here?
Yes, so of course the first step should be more intense lifestyle behavioral changes. This would mean a healthy, balanced diet. We should remember here that the extra 300-400 calories that are required during pregnancy are not required this early, that is later on. And so the diet should be balanced, focusing on nutrient-dense foods, not too much of calorie restriction, not too much of carbohydrate restriction. Again, regarding exercise, the perfect exercise regimen for pregnancy, whether resistance, whether aerobic, that is not known. But simple things like walking for 15-20 minutes after every meal, or not sitting for prolonged periods are helpful. So this I will try for a couple of weeks or so, within which if the targets as mentioned, fasting less than 95, 2-hour PP less than 120, that is not met, I would start her on insulin.
Fair enough. So Dr. Jugal, again, how do you monitor sugars in pregnancy? Are you using continuous glucose monitoring? Are you using SMBG? What is your recommendation? What are your goals?
So most commonly we've been using SMBGs, and the way to do SMBG is your fasting 2 hours after breakfast, 2 hours after lunch and 2 hours after dinner. Most of the time these 4 suffice. Yeah, there are occasional patients where you want all the 6 readings, that is all the pre and the post meals, especially when you're adding too much of the basal bolus of both sides, or that is in the morning and the night as well. The other thing is the targets, which we've already discussed. The pre-meals should be around 95 and the after meals should be somewhere around less than 120. Having said that, all your SMBG meters come with a small amount of error. We need to understand no two SMBG monitors, even of the same company, will give you the same reading at the same time. So it is always a good idea to check the lab sugars, which are far more accurate, at least once in 2 weeks, so that you're not over or under treating, especially on insulin, because hypoglycemias are very detrimental. The last thing is a CGM. So currently CGM is not approved in pregnancy, but we are using, because a lot of patients get really irritated with the number of pricks that have been going, which is roughly like 4 or 5 times for the insulin and 4 or 5 times for the SMBG. Even with the CGM, you need to be careful on the trends because your CGM has a 15-minute lag. It's an interstitial blood glucose. So you may be reacting a little too late at times as well. And you need to even take care that in the pregnancy as you progress, there is a lot of hemodilution. So there are a little more inaccuracies there. And you will have to do an SMBG maybe once or twice a day. That is what I usually do if the patient insists that I want to be on a CGM. And obviously the lab sugars should be done once in 15 days. So you are not over or under treating your patients.
So Dr. Richa, again, under your excellent care, she's delivered a healthy female child of 2.8 kilos, not macrosomic, so you've done an excellent job. How do we counsel this patient at this last visit when she's come to you during pregnancy or rather immediate postpartum regarding her postpartum surveillance going forward for herself and her baby?
So this was a patient of type 2 diabetes mellitus and controlled well on insulin. So after the delivery, insulin resistance comes down drastically and insulin requirement also will come down. Patient may be managed only on diet and exercise, maybe metformin. So we need to be careful about the insulin dosages and the anti-diabetic dosages that we are doing. So this was type 2 diabetes mellitus, so where we are not, we are continuously monitoring the patient. But in a patient of GDM, generally GDM tends to resolve after delivery. So where we have to again call the patients in 1 month to 3 months to do OGTT. In this patient it's not required, but in GDM patients we will do OGTT, 75 gram glucose test with non-pregnant diagnostic criteria at between 4 to 12 months. And GDM patients will require lifelong surveillance because GDM carries 10-fold risk of development of type 2 diabetes mellitus. But in this case, I mean, this is a continuous surveillance, I would say, and the patient would also need to be counseled about contraception and about, psychosocial counseling.
And what is your opinion about breastfeeding for this child? Suppose the patient is breastfeeding, not manageable on metformin, again with her sugars. What would you advise in that kind of scenario?
Right, so the anti-diabetic drugs, they are secreted in breast milk, but no really, there is no adverse data regarding their usage, and very little amount is secreted. Insulin would be ideal, but as we know, after pregnancy it will be very challenging to put the patient on insulin. So I would say if we are able to maintain on lower dosages of anti-diabetic agents, that's fine.
Ideal case scenario, absolutely. All right, so we'll go over to our third case now. This is another friend, Meeta. She is 28 years old. So she's come to you, Dr. Nilakshi, for the first time with a BMI of 28. Her waist circumference is 90. She is again planning pregnancy and she says, Doc, am I overweight? Would you call me obese? And what should I ideally weigh if I'm planning pregnancy? How much weight gain can I have if I get pregnant? What would you advise her regarding all her weight management?
Obesity is a growing epidemic these days, and it is common for women in reproductive years to be obese or overweight. So in this case, we would rather call her overweight in this scenario. More than 25 would be overweight and more than 30 would be obese. And since she has a BMI of 28, so she'll be overweight. But then again, she is a proper candidate whom we should advise good lifestyle modification of losing her weight. We can also tell her that being overweight is again a risk factor for subfertility, because weight that really affects high body weight, it affects the ovulation process, because we know hypothalamic pituitary axis is a very precarious axis. It's a dynamic axis and it is easily influenced by higher body weight. In fact, people who are undergoing IVF have lesser success rates if their weight is on the higher side. So we should tell her that being overweight or obese puts her at a higher risk of being less likely to become pregnant sooner. And even if she happens to have a pregnancy with that amount of weight, she's again going to be at a higher risk of gestational diabetes, she's going to be at a higher risk of gestational hypertension, macrosomia in her infant, greater chances of congenital defects in the neonate or in the fetus because of higher body weight of the mother. Again, the need for requiring C-section would be higher in obese mothers, and the chances of wound infection are high. And a woman who is obese and her child is also, again, it's a transgenerational transmission of obesity again. The child is also more likely to become obese in the later life as an adult, and again repeat the same metabolic illnesses once again. So this is a high time that we tell her that it is important to maintain her body weight at an ideal level. She should start exercising regularly and eat a healthy balanced diet, which includes a lot of nutrients, which is high in nutrition and low in calories. So she has to balance her diet and exercise in order to achieve an ideal body weight.
Thank you. I will add over here the WHO guidelines. It's true, 25 is obesity, 25 is overweight. For our Asian cutoffs, we call 23 overweight and 25 obese. So from that perspective, if we were to classify her from an Asian cutoff standpoint, this woman is already obese also as well. A waist circumference of more than 90 centimeters in females again would be considered high. 80 in females is high, 90 in males for that matter. So this woman, even by waist circumference cutoffs, would be considered high risk from a weight standpoint. So Dr. Sunetra, specifically to you, if she asks you, will the obesity per se impact fertility? What is your advice to her?
Yes, of course. So for every 1 kg per meter square increase in BMI, the odds for spontaneous conception has been seen to fall by as much as 10%. Several studies have quoted figures between 25 to as high as 75% for the rates of subfertility and infertility in overweight obese individuals. So when we are talking about obesity and infertility, I'm not talking about diabetic. Those who are diabetic, even in those without diabetes, the first thing that comes to mind is a diagnosis of PCOS. So the hyperandrogenemia, the insulin resistance, the changes in SHBG, the LH pulsatility change, hyperestrogenemia, we know all of these contribute to ovulatory dysfunction in PCOS. But even in obese women who are not having a confirmed diagnosis of PCOS, they do have the same hormonal changes to some extent. Additionally, other mechanisms have been proposed due to changes in the leptin-adiponectin ratio and other adipokines. The intrafollicular fluid, there is some biochemical changes which is not very good for a developing embryo. Also, there is direct lipotoxic damage due to free fatty acids which causes embryo fragmentation. There is altered receptibility of the endometrium to the embryo, all of which can contribute to infertility. Also, recurrent infections and endometriosis in obese women can contribute to a tubal factor infertility. Even ART outcomes are poorer in overweight to obese women.
Absolutely. So, Dr. Jugal, at this point of time, what are you recommending? Any tests for her from her obesity standpoint? And what are the treatment options? Nowadays, we have these anti-obesity drugs that are going through the roof, left, right, and center. Do you think any of them are options for her?
So coming to the investigations, I think you just need to do your rule out diabetes. You need to do an OGTT if it's not been done, or a fasting on an A1C also helps you to screen, and a thyroid function test. Besides these two, lipid profile also will help you to motivate the patient if there is dyslipidemia to adhere more to diet and exercise, because statins are contraindicated if you're planning. Coming to the anti-obesity medications that we have galore, but I think we do not have enough safety data when you're actually trying to plan a pregnancy, put the patient on, and once they conceive, you stop, because there will be an after effects for something like an GLP-1 analog as well. So those are really, really attractive options, but they are not considered to be very safe till we have enough data. So the only option that you're left with remains is metformin, which is not only safe, really efficacious, hits the target, that is insulin resistance, to a good extent even has a little bit of appetite suppression, so helps you adhere with the diet and the exercise routine really well.
Great. So it's again metformin to the rescue again over here as well. So Dr. Richa, this patient asks you, now that I'm pregnant, is my weight going to impact my pregnancy, and is my pregnancy going to impact my weight? What do you explain to her?
Yes. You know, any woman who is obese and becomes pregnant, we generally, ask the patient to gain less weight. I would say in this patient, I would say in general, patients gain around 12 to 14 kg weight gain, but in this patient, we would say lesser amount of weight gain should be done. Something like, I would say, 8 to 10 kgs of weight gain that should be allowed to this patient. And in any patient who is obese and becomes pregnant, there are more risks of complications, more risk of pregnancy loss as well as stillbirth, so more surveillance would be required.
Absolutely. So Dr. Nilakshi, now obviously we need to maintain a balance between giving a good diet to her because she's pregnant. You don't want to, this is not the time for severe diets. So what is the diet and exercise regimen do you recommend to your patients during pregnancy now?
As we discussed a little earlier, a healthy diet is the key to rescuing such patients from obesity and diabetes during pregnancy. So in a woman who is having diabetes and obesity, so we would ask her to have more of nutritious food which is high in nutrients, high in fiber, lean protein we may include, a lot of whole grains, fruits and vegetables should be encouraged. We should discourage her from having high calorie diet like sweetened beverages and those fast foods which we normally have these days, cakes, candies, chocolates, those should be discouraged. And as regards exercise regimen, it should be walking during pregnancy because she cannot take up strenuous exercise during. So based upon her medical condition, if she has any associated complications during pregnancy, like those have to be excluded. If they are not there, like spotting or placental insufficiency, if it's not there, she can start with walking, and that walking can be, we can start it at a shorter duration and then gradually escalate it once she tolerates it. So maybe starting with 10 minutes of walking per day initially, then increasing by 10 minutes each week is a fair idea. Though swimming is not very common here in our part of the country, swimming is a very good option for women who are pregnant because that doesn't put strain or strain on any of the muscles specifically. It's buoyant, so that helps.
So just mild and moderate exercise would be a good recommendation. Lastly, Dr. Sunetra, the patient under you now has delivered a 2.0 kilo healthy female child. How would you counsel her postpartum again from an obesity standpoint for herself and her child?
Okay, so assuming she did not develop GDM,
yes.
So yeah, of course the healthy habits that she has acquired during pregnancy, that she has to continue lifelong. And again, she will always be at a high risk of pre-diabetes or diabetes. So 1 to 3 yearly screening is important for her. And inter-pregnancy weight gain, if she is planning another pregnancy, that has to be taken care of. That should not be too much. And again, the child, regarding, it's good that she did not deliver a SG or LGA baby. It's a normal weight baby, but still, again, too much of catch-up growth should be prevented so that he or she does not go on to develop pediatric obesity.
Right, so you start giving these lessons from early on. All right, thank you very, very much to all our panelists for going through these clinical cases with us. I invite Dr. Manjari back to thank everybody.